Yeah, thank you. So we will discuss about neuro monitoring and ECMO. It is a
So
very important.
you are not audible, sir.
Uh-huh.
Sir, no, sir, you're audible.
Pranay, they're saying I'm audible. I'll continue. Neuro monitoring is one of the very important aspects. In case you cannot hear, please let me know. It is very important aspect of ECMO because for putting a patient on ECMO, first of all, we will make sure patient's neurological status is appropriate. If the patient is in a state of brain death or having significant intracerebral bleeds, then we would not like to put the patient on ECMO. I'm sure you know about this, why it is, because all of these patients will be going through heparinization phase. So it is very likely for increase in the bleed in case they are put on ECMO. Already if they are bleeding. So we'll be very careful about making sure there is no coexisting bleed before they go on to ECMO. And there would be some difficulty in assessment as well. We will go through that in the next few slides. Clinical monitoring aspects I will discuss, imaging and other modalities. It is the most important organ because it decides about outcome from the ECMO. At the end of the day, what you are trying to do is provide adequate oxygenation and blood supply to the brain without deforming its integrity. That is our ultimate objective at the end of the day. Though we are dealing with other target organs such as the heart and lungs, it is a key factor in accepting a patient for ECMO, as I mentioned, and decides the course of ECMO as well. At any point of time during the course of ECMO, if you if you notice there is an intracerebral bleed, then you will re-evaluate what to do at that stage. ECMO risk factors are, for the sake of bleeding in the brain, are ischemia, hypoxia, and hypotension. Heparinization itself doesn't let a patient bleed into the brain. For example, if it's a normal patient without any of these predisposing factors, such as ischemia, hypoxia, hypotension, they won't be bleeding into their brain. So when there is a complex interplay between these three things are happening, patients tend to bleed into an ischemic area. That is very, very important. Systemic heparinization can worsen it if there is a uh, pre-existing ischemic focus, but otherwise they don't bleed, they don't let any patient bleed into a normal tissue. Impairment of cerebral autoregulation could be a factor. This is a matter of research at this point of time. Now, it didn't come into clinical application still, but certain colleagues are working on finding out the importance of cerebral autoregulation during the process of ECMO. Obviously, there will be a microemboli. No ECMO will happen without any microemboli. And if there is a pre-existing uh, ventricular septal defect or patent ductus arteriosus, it is likely that it can pass towards the brain. Effect of carotid ligation and reconstruction may have some impact as well. Children usually tolerate carotid ligation reasonably well, as the opposite side and the same side vertebral artery takes care of that part of the circulation to most of the extent. And regarding the reconstruction, surgeons usually decide to reconstruct if the underlying the vascular endothelium, it has a necrosed and it is possible to repair it, then they tend to repair it. But one has to be very careful about aneurysm formation in the post ECMO follow-up phase for months to years together to make sure the reconstruction has settled very well. Now, one point here is patients do tolerate ligating the carotid artery, but not internal jugular vein. So the venous circulation, if it is bilaterally ligated, that can lead to devastating effects on the brain by increasing the venous congestion and patients can die. So one has to be very careful about not using both the internal jugular veins. The difficulty in assessment is because of the effect of sedatives and paralytic agents. There is a need for readily available dynamic tests, but these tests may not be available all over in all ICUs. Transporting a patient on ECMO with cannula and pump is not easy. We will learn about this in the transport medicine. Physiological closure of a window such as anterior fontanella in infancy reduces the chances of observation of what is happening in the brain as a non-invasive basis. In ultrasound can be used in a neonate or till um, in the early infancy too, till the anterior fontanella closes. Despite the risk of over and under cerebral perfusion, ECMO protocols are based on systemic outcome metrics rather than brain-specific metrics. We always talk about recirculation factor, how much blood is going on, is getting oxygenated, circulated, tissue perfusion, etc. But they are not brain-specific metrics, leaving the brain at risk of injury. The CNS complications which ELSO has decided to watch are bleeding, ischemia, seizure activity, hemorrhage, stroke, and brain death. So for each and every patient that goes on to ECMO and the data gets reported to ELSO, people have to submit data regarding these 6 parameters to the ELSO registry. To show you about the data from the international summary, here you can see the 6 parameters being monitored here with variable survival rates. If there are seizures, people can withstand, nearly 50% of them survived. But when it goes to major issues such as diffuse hypoxia or hemorrhage, intraventricular bleeds, etc., less number of people have survived to discharge. So that is the importance of these parameters. Again, you will be able to notice this from the ELSO registry data about neurological criteria such as parenchymal CNS hemorrhage in various age groups here, and how the data has changed over a period of years. Probably you can notice that in the recent times towards 2021, more number of people are surviving. That is for better appreciation, early recognition, and treatment possibly. So multimodal non-invasive neuromonitoring in adults undergoing ECMO has improved the results significantly. These multimodality measures, if they are available, they include diffusion correlation spectrometry, transcranial Doppler ultrasound, EEG, brainstem responses, auditory brainstem responses at the bedside, and developing a cerebral autoregulation metric. They have tried this on experimental basis on 2 patients, a research basis on 2 patients, demonstrating the feasibility and laying the foundation for future studies monitoring neurological health during ECMO. So this is from Irfan Dar et al. So they have shown that the multimodal monitoring, including different modalities, will improve the possible outcomes on ECMO. The phases of neuromonitoring are pre-ECMO, watch for seizures, stroke, cerebral ischemia, and hemorrhage. Ideally, in doubtful cases or when there is fixed dilated pupils or some irreversibility in the size of one pupil compared to the other pupil, etc. Whenever there is a doubt, ideal is to do a CT scan and rule out any pre-existing problem before we consider to put them on ECMO. But it may not be possible in all the cases, as these patients tend to be extremely sick at that point, may not tolerate a visit to CT scanner. Post ECMO, yes, certainly we can follow them with the CT scans, MRI scans, and neuropsychological evaluation. Please remember, during ECMO, no one will do MRI because the cannulae are not compatible with the MRI, neither the console. Okay, So don't think of MRI while the patient is on ECMO. Clinical monitoring is by daily frequent assessment of neurological status, GCS observations. All these things have to be written down in daily patient notes. Pupillary examination, assessment, mobility, neurological deficits, seizures, and if there are any gadgets such as the scan or EEG showing interpretation, those things I will deal with in the next few slides. So nothing to replace the clinical monitoring. It is very, very important to assess the patient clinically uh, daily as well as many times in a day. Pupils, very briefly, changes in the size and equality and reactivity of the pupils is very important. Bilateral, dilated and fixed pupils are important for you to watch further and investigate further to see if there is anything happening in the brain. So they would need going for a CT scan or ultrasound scan in a neonate as a dynamic measure to start with initially. Dynamic pupillometry provides several objective biomarkers. It is available. I will show you one of those in a minute. Unreactive pupils can be caused by expanding mass, such as a blood clot, exerting pressure on the oculomotor nerve. So that is important. Unilateral uh, constricted pupil is very important to notice as well. Um, and check if there are any pre-existing factors such as cataracts, pre-existing eye surgical issues, etc., which can interfere with the interpretation of these pupillary responses. New onset changes are important as a screening test too. Damage anywhere along the route of the optic pathway can cause abnormal static or dynamic pupillary uh, responsive nature. So this is the light reflex. As I was saying, anywhere interruption along the pathway of light reflex can cause different interpretations as well, different findings when we are monitoring the pupillary reflexes. This is pupillometry. It tells us the exact size of the pupils when you attempt it. One of the useful devices to have. EEG, you all know about EEG. It can be done for an hour or two or a continuous electroencephalogram as well when patients are in ECMO. Both would be useful. Alpha to delta ratios can be calculated from the alpha and delta waves. Patients with neurological injuries have also been shown to have a lower alpha to delta ratios compared to those without injury. So this is one of the examples showing EEG demonstration, how it can look like. Can be done on site in the ICU, and this is cerebral function monitoring, which we tend to use a lot on neonates on ECMO. This is a bedside tool. And the leads are limited to 4 or 6 in the CFAM or cerebral function audiometry, cerebral function monitoring, cerebral function monitoring CFAM. In this, unlike EEG, which has got 12 to 18 electrodes on this. So it is a sort of summative data we get on this, closer to the baseline recording that shows patient is very depressed with respect to CNS status and the electrical activity, or in case of brainstem death, etc., that can be very, very low, close to zero as well. Severe sedation can also cause this. So once the sedation is lightened, the waveform tends to get better also. So this is the waveform pattern here. You can see the band, which is a healthy band actually here, around 25. Is in a sedated patient, it looks like this. In an awake patient, it is between 50 to 100 microvolts, and in a comatose patient, it would be closer to zero here. So that gives you an approximate idea of how the cerebral function monitoring looks like. This is a seizure pattern here. You see the variability in the size of these waves. as a band pattern. This happens when there is an ongoing seizure. When there is when there is a mechanical interference as well, this can happen. So usually people tend to write down if there is something like suctioning is done, some sort of interference is done, and people tend to make a note like this procedure was done at this point of time. So that will be helpful in analyzing the data. Okay, so here you can see somebody has mentioned suction was done, so the waveform has gone up, and again after the suction it came back. But this is not very good as it is close to zero here, 0 to 2 microvolts, 0 to 3 microvolts. This is a very low voltage. It can be confirmed with the EEG afterwards, as it is very important feature. Ultrasound in neonates is a very valuable tool, as it is a dynamic tool and can be done many times in a day as well if we need to interpret in expert hands. It has shown like in 46 out of 49 cases of major intracranial hemorrhages, they were able to identify it on sonography itself without a need for going on to CT scan in neonates. So this is as per Bulas et al. So it depends on the operator sensibility and criteria, and operator specific criteria as well in identifying an intracerebral bleed. Beware of choroid plexus as it mimics collection. So people who ultrasonologist or intensivist, whoever is doing the scan, should be aware of choroid plexus and in differentiating it from grade 3 or grade 4 intracerebral bleeds. Intraventricular bleeds too. Isolated subependymal hemorrhages don't matter. If it is a major one, then only that is grade 3 or grade 4, then it matters as a contraindication for going on to ECMO or consider coming off ECMO. Daily sonograms are recommended. So this is how an ultrasound looks like in a normal baby. And here the dense structure you are seeing in the ventricular groove is choroid plexus here. Auditory brainstem responses are also helpful. Injury to the specific regions of the auditory pathway, such as brainstem, can be determined by measuring the latency of the specific peaks in the response signal. Neurological injuries also showed delayed latencies of specific waveforms or no waveforms at all in response to auditory stimuli in patients on ECMO when they suffered neurological injury. So it would be helpful too. Diffuse correlation spectrometry, a lot of laboratories may not have it, but it is a useful tool. It uses the interaction between the light and moving scatterers, such as RBC, in the cortical microvasculature to obtain blood flow index as a surrogate of cerebral blood flow. So it is a useful parameter to have, but not a absolutely necessary, or it is not mandatory to have it when you are having an ECMO center. Transcranial Doppler is also useful. It measures the cerebral blood flow velocity of deep cerebral arteries. Cerebral blood flow velocity from transcranial Doppler and the blood flow index from diffusion correlation spectrometry have shown good correlation too. So this is something like multimodal monitoring, very helpful. We worked with the near infrared spectroscopy for a decade and a half. This is a good reflection of global brain tissue oxygenation. There are two probes. One probe is tend to keep it over the region of the kidneys as the somatic saturation, and the second probe over the region of the brain, that is over the scalp, as the cerebral saturations. Here you can see S and S systemic saturations here 70, 79 around that, and the left side, right side is showing around 65. Generally, what would you expect is if the somatic saturations are close to 80s or 90s, then 2/3 is the number you expect from the cerebral saturations. If the cerebral saturations are very low, like less than 40, that is a problem as well. That shows tissues are oxygen hungry, or the brain is oxygen hungry, or if the cerebral saturation is very close to systemic saturation, that is also a problem because oxygen extraction is not taking place in the brain. So both are problematic. It works in the form of producing photons, which are reflected into the brain tissue. They return and they exit the skin. They are picked up by the two light sensitive uh, uh, photodiodes, and this is reflected as a value here. So low NIRS index has been associated with cerebral dysfunction in cardiac patients, such as less than 50 or index of more than 20% decrease from the baseline. Both are problematic. Here is a picture of one of the babies who was an ECMO with cerebral function analyzing monitor on over the brain, scalp electrodes. So the scalp electrodes here. And this is how it happens. The photons are reflected into the brain tissue, and once they come back again, the diodes they measure, they pick up, and they display it as a value. As I mentioned earlier, if the somatic saturations and cerebral saturations both are same, that's a problem, and both are low, that is also a problem. So there are studies in adult literature as well as in pediatric literature showing that the regional oxygen saturation, cerebral saturation measured by multi-channel NIRS in an infant supported veno-arterial ECMO. And this is more or less a standard of practice in majority of the centers in the Europe and US. Our country is also using in some ICUs, as I know. CT scans on ECMO can be done and are very valuable. Every center has to practice taking the patients on ECMO to a CT scanner and bring back as again, because this is a challenge to take them to the CT scanner, transfer them onto the table, get the CT scan done without displacement of the cannula, and bring them back. So each and every unit has to try this. It is mandatory. Non-hemorrhagic or structural lesions, and when ultrasound was normal, CT was abnormal in 7% of the cases by Garber et al. But once the anterior fontanella closes, as there is no other window, this is very important for us to monitor the brain on CT scans. Preparation, personnel, planning, and execution are very important. It can lead to hemorrhagic stroke also. Seizures and ECMO are important. The management is the same like we do in patients not on ECMO with anticonvulsants, but see the underlying cause, what could be that, and try to treat the underlying cause as well. CFAM, continuous EEG, or EEG for 1 or 2 hours, both would be useful too. Stroke and ECMO can happen as a result of microembolic events or rapid reduction in the PSCO2. Please don't do that. Gradual reduction in the PSCO2 is advised because rapid reduction leads to cerebral vasoconstriction, and that would be disastrous. Hemodynamic instability, shock, or a combination of these factors can lead to stroke and ECMO. The management is monitor. You can do the investigations as far as possible. CT scans, optimal transfusion management is not yet determined about it. So the management of the CNS events are supplemental oxygen to keep the oxygen saturation at 94% plus. Cardiac monitoring for arrhythmias or see if there's an atrial fibrillation. Address the cause. Keep it as a normoglycemia, slightly higher, but ideally normoglycemia. Pneumatic compression devices for preventing DVTs, early mobilization, mechanical intravascular or neurosurgical intervention for thrombectomy, early intervention as for the MDT decision are very important in treating and managing these neurological events. Suggested measures are, yes, there in some centers, neurointerventional radiologists, they tend to help with mechanical thrombectomy with large vessel occlusion within 6 hours. Yes, these are the neurointerventional radiologists. They have been very helpful in operating on patients and ECMO as well. But as a team, we all need to exercise this. Hemorrhage and ECMO, yes, it can happen. Monitor, you can do heparin-free ECMO when this happens. See and weigh what is the advantage. Can the patient come off ECMO needs ECMO desperately. Monitor the numbers, APTT, antithrombin, SA, etc. Replace the clotting factors if it helps, and watch how the intracranial hemorrhage is progressing. Intracranial hemorrhage has a mortality of 80 to 90% as per ELSO registry data, so one has to be very careful with this. If ECMO is life-saving and the patient is very likely to die if he comes off ECMO, um, in view of this intracerebral bleed, you can consider an heparin-free ECMO for that period. Most important is dynamically watching what is happening to this bleed over a period of next few hours, and you can take a decision about continuing the ECMO or stopping the ECMO. Okay, so this is a MDT decision at this point of time. In neonates, severe intracerebral bleed, intraventricular bleed can look like this. People are studying cerebral autoregulation in pediatric ECMO, and they are coming out with very important information as well, which will be very useful for us in future. They are this is the way how they study impairment of cerebral autoregulation in pediatric ECMO. Lakshmi Raman is our colleague in Dallas. She often deals with this topic in our ELSO or as well as in ECMO Society of India teaching programs. So Lakshmi is doing tremendous work on this. We all appreciate. So with the neurological complications, reducing the incidence in the last decade may be due to better management and technology, or it could be underestimation due to non-reporting earlier. So the follow-up is very important at the end of the day. Once the patient comes off and is discharged, neurodevelopmental clinics and involvement of neurologists, psychologists, neurorehabilitation schemes, they are very important. Relevant scans have to be done. In neonates, repeated ultrasound scans will be helpful, and also CT scans or MRI scans in the post-ECMO period. CT is useful for identifying infarcts, diffuse edema, and atrophy. MRI gives a much better delineation and greater range of available soft tissue contracts, depicts anatomy in a greater detail. Scans are also helpful. The take-home message is neurological monitoring and ECMO is very essential at all age groups. Clinical as well as supportive tools should be made of in monitoring the patient pre-ECMO, during ECMO, and post-ECMO. Transport for CT scan involves operational challenges. Preparation is the key, and every center should do this at some stage or other. It becomes necessary for taking your patient on ECMO to a CT scanner. Cerebral autoregulation is a new evolving entity, and we are yet to learn about this, and follow-up is mandatory. So with that, I end my talk. If there are any questions, I'm very happy to answer.